Good morning, everybody, and happy Tuesday. I almost said happy Monday, but happy Tuesday. Welcome back to your Lunch Break Live with me. My name is Ivana, if you are new here. And I hope all of you had a wonderful holiday weekend. I know I did. I know I enjoyed it. But we're back. Today's Tuesday. It's the start of a new week. And today, I thought it would be helpful if we talked a little bit about probable cases of coronavirus and also some of the things that lead to those probable case numbers. Now, if you've been paying attention to the Alabama Department of Public Health coronavirus dashboard, that's a tongue twister, then you might see those numbers that there is a probable case count area of that dashboard where they keep adding cases there. But it kind of begs the question of what is a probable case and why is it different than a normal case of coronavirus. So today we're going to talk all about that. I have got our own Dennis Pillion here to explain probable cases. Why are they called that? What goes into accounting for a probable case and more. So if you have questions about probable cases, antigen testing, anything like that, leave them in the comments. I will be monitoring them and I will ask Dennis as we go. I'm also going to share my screen here in a few minutes so you can see some graphs that might help a little bit explain those probable cases. So Dennis, first, thank you for getting up on your Tuesday that feels like a Monday and talking with us.
Glad to be here.
First, let's talk about number one, what are probable cases? I'm looking at the ADPH dashboard right now, and as of this morning, there are 11,727 probable cases. What is a probable case?
Yeah, so this has caused a lot of confusion lately because the ADPH has kind of been changing how they present their data on the dashboard, and they've really been providing more detail, but it's confusing. It's in a different way. We talked to State Health Officer Dr. Scott Harris, and basically his message is that as far as ADPH is concerned, probable cases are cases. So it's not that they're less confident in the diagnosis, which is why they're probable. It's just that they reach that status a different way. So there's two big ways that you can be probable. One is if you have a known exposure to someone who tested positive. Say, if my wife had it, tested positive, I also displayed symptoms, but I'd never bothered to go in and get a test. If they get word of that, then I could be reported as a probable case because in all likelihood I had it. I just did not bother to or was not able to get tested for it. That also includes people who unfortunately passed away from and COVID-19 was written on the death certificate. But if for whatever reason they were in the hospital, they were really ill, and if COVID-19 was listed as the case of death, as the cause of death, but they never got that test, then they would be listed as probable. That is kind of we don't actually know the breakdown, but just based on following the numbers, it seems like that's kind of a very small percentage of the probable cases. It seems like over the past 3 weeks or so, 2 weeks maybe, we've had a large number of those probable cases. We went from like 4,000, from March until mid-August. So now, as you said, we're up over 11,000. And the biggest reason that has just jumped and gone so high are what's called these antigen tests, or this, the more common term you would hear is a rapid response test. So it's a test. Yeah, sorry, go ahead.
I was going to say, why are those rapid response test results included in probable and not just in the overall case count?
Yeah, so the big reason for that is kind of, as Dr. Harris would say, that's just kind of the way that the epidemiologists classify the data to make sure that when you're comparing stats from state to state and from the early stages of the outbreak to now, that you're kind of comparing apples to apples, right? So it's not that if you test positive on this antigen test, the rapid response test, first of all, those things, they can be really, really helpful in this because you can get the results back in 15 minutes, okay? So you don't have to send them off to a professional lab, which could take, days. In Alabama, sometimes when there's a testing backlog, people are waiting a week or more for results when they can get results back in 15 minutes with these antigen tests. Now,
So I want to talk about those antigen tests, but first, we have so many people commenting, they're watching, and thank you so much. We appreciate having you back. I know we got some frequent viewers here, but I have a few questions that I want to get to you, Dennis, before they get too far down the comments, but especially about that first reason that some cases are considered probable. And that is because you said you might be in close contact. Maybe you live with somebody who gets COVID, you have symptoms, but for whatever reason, do not get a test. So number one, let's say that my husband gets COVID, I have symptoms, I don't get a test. How would ADPH know to add me to that probable case number?
That's a good question, and I don't know the exact answer. I know that ADPH does do contact tracing, so it's possible that that is, something when they do a contact tracing or a case investigation from someone who has a confirmed positive test, they might decide to count. I don't actually know how they do that. That's a good question that we should probably ask ADPH.
Right. I'm sure that a lot of people have that same one. Now, yeah. We also have questions about the people that are dying and being added to that probable case count. We have some people saying, look, that's a little bit confusing. Why are they not getting that COVID test when they're in the hospital? And if that test comes back as positive, then why is it being added to probable?
Well, if they were in the hospital and the test came back positive, then they would be a confirmed case. But again, I would say that's kind of one possibility. We don't have an exact breakdown, so we don't know how many that is. But as we'll see in the graph later, the number of probable cases in the state really kind of tracks with this antigen testing. So it doesn't seem like there are very many people at all. It's possible that you could get added as a probable case that way, but it doesn't seem to be happening very much.
Right. Okay. So most of those are those antigen tests. So let's shift and talk about those. Now, we know those antigen tests are being more frequently given because of colleges and universities in the state, because of nursing homes, things like that. We've got some people saying, like Samantha says, my daughter had a false positive on the rapid tests. And we've got some people saying, look, are those rapid tests effective?
So with the rapid tests, there's two kind of measures that epidemiologists use to measure how effective and how good these tests are. As far as false positives, the chances that you could take a rapid test and it would show positive when you don't actually have it, both of the rapid tests that have been approved so far, they are reporting 100% to be just as good at weeding out false positives as your standard PCR tests. So when someone has a positive result from the rapid test, ADPH, the CDC, everybody has just as much confidence in that as the standard, what's called a PCR test, which is what everybody has been doing since March. The rapid tests are just as positive, as good there as the standard tests. The drawback with the rapid tests is that sometimes you can miss cases, right? Basically, the standard test that we've been using since March is called a PCR test, which basically means they stick the swab up your nose, they send that sample off to a lab, and then the lab multiplies the virus. It grows the virus out. So when it does that, it's very unlikely that it's going to miss a case, right? Because if you have the virus, they're going to put it on that swab, they're going to run it through this PCR process, and it's going to multiply any viral particles that are there. So you're not going to miss anybody. The antigen tests, these rapid tests, they don't use that step, okay? So basically it's the same thing. They're giving you a nasal swab. They're running it through the reaction. And then if it's looking for the actual particles of the virus itself, but it's possible that you might have the virus, but maybe your viral counts are very low. And so it might test negative when you actually do have the virus. If you had done the PCR test where they send it to the lab and they grow the sample out, if there's a small amount of virus there, it's possible that you can test positive through the PCR, but negative through the rapid response test.
That's really interesting. I know we have JM saying that's scary. It is kind of scary, JM. Kathleen, I think, was asking, let me repeat that. I have this written down so I get it right. So there is a higher false negative rate on the antigen or rapid response test, but a low false positive. So just wanted to repeat that so we've got it. Again, we're going to link a story in these comments Dennis wrote for us over the weekend that has a lot of this information in it. But I just wanted to go ahead and put that out because it is very confusing. Now, while I am looking through some of these comments, there are some people who are asking, where do you get those rapid response tests? Are those the ones that you're getting at most of these drive-through testing, or is that more something you have to go to a doctor's office for?
So, and that answer is actually changing a lot because these rapid tests are becoming a lot more widely available. A lot more places are getting them. Right now, and actually, I live here in Birmingham. There are several kind of after-hours clinics, places like that, where you can get these rapid response tests. Most of the drive-up test centers, they have been using the standard PCR tests where they send it off to a lab. And again, the biggest difference is, do you get your result in 15 minutes or do you get it in, 2 days or longer?
Mm-hmm. And I see a comment from Linda that could be really helpful for us. She says that when we were talking about how the ADPH is maybe getting some of these numbers about close contact, she says they, meaning I guess doctors and medical professionals, ask the positive patient who they have been in close contact with, and then the health department calls and tells you to quarantine. She said that her husband had COVID. Linda, we hope he's doing better. And she said that she was called by the health department. So a good little tidbit there.
Yeah.
Thank you, Linda, for sharing that with us. Now, I'm going to, if I can get my computer going, I'm going to share with y'all this 7-day average for coronavirus cases in Alabama, this chart. Now, keep in mind, this chart went through September the 4th, so it's about 4 days old, but I thought that it was interesting to show you just kind of the differences in the 7-day average for cases not including probables and cases that are including these probables. So this darker line right here is the 7-day average of coronavirus cases. Now, the lighter color that is on top, that's that 7-day average with probable cases. So Dennis, let's just quickly talk about what is the difference in these two lines, and is it, when it started, because when the Alabama Department of Public Health started including probable cases, but also how those probable cases have changed over time. We see kind of lately there's been a much bigger spike in probable cases versus actual, quote, actual cases.
Yeah. And you can see there, for most of this outbreak, those two lines are very close together. I believe, I would have to double check this, but I believe the first antigen test got approved by the FDA in June, possibly July, but I think it was in June. So at that point, then you start seeing a few more probable cases, which are some of the earliest places that had access to those rapid tests. And then, you can see there's a point down in there, I think it's August 17th, where all of a sudden the number of probables shoots way up. And that's because a lot more people have access to these rapid tests. And so they're using the rapid tests, which means they're probably not also using the PCR tests, the old standard tests. Mm-hmm. So probably that's going to be the situation going forward now, because more and more places are going to have access to these rapid tests. People like them because they don't want to have to wait, 2 days or longer to find out whether they might have it or not. And they're also less expensive. It requires less lab equipment. Less personnel. You don't have to send it off somewhere, and so it decreases the cost that way. Mm-hmm. So there's a lot of advantages to these antigen tests, but it just shows, as to people were concerned earlier, about deaths. About probable cases being added from death certificates and from case investigations, or like you said, the department actually contacts people who have the disease to see who their close contacts are. But it seems like the vast majority of this are from those antigen tests. Mm-hmm.
We have somebody, and I cannot remember or find who exactly it was, but somebody asked, it was JM, wondering, can I order some of those rapid response tests? Can I have them delivered to my home?
I don't believe you can do that yet at this point, but there is an initiative through the federal government where these a large number of these rapid tests are being allocated to the states, and there's a suggestion, maybe that they be used for schools. There's a different program that's looking to get these rapid kits out to nursing homes, and these kind of I guess high leverage, high profile situations like that. Mm-hmm. So we're going to be seeing more of that. We're going to be seeing, schools, maybe some businesses will be able to kind of get the kits on their own, and they can rapid test their employees and know, in 15 minutes whether they might be positive.
Mm-hmm. Well,
So
I think it's interesting the amount of people who are talking and wondering about this probable case count for those people who have been in close contact with somebody diagnosed with COVID. I know we had Linda said that she got a call from the health department after her husband tested positive. We've got Robin saying that did not happen to her. She said she tested positive and she was never asked who she had been in contact with. So I think that, Robin, I think you're really pointing out something that a lot of people have questions about, because a lot of testing sites are not doing the same things. They're not asking those same questions or getting that same data. I know somebody said, well, this is contact tracing, but we don't have any statewide contact tracing, Dennis, do we?
No, we do actually. And it's obviously they are not reaching everyone, but the health department is doing, they call it contact tracing or case investigations, but they are, they swear up and down that they're trying to reach every person who tests positive and see what their contacts were. Obviously, in kind of July, early August, that got to be an almost unmanageable task just because there were so many positive cases. But they are staffing people. They have pulled in UAB to kind of get some help doing that. But it's kind of just a manpower issue with the health department. They're not able to do all of that contact tracing, even though they are trying.
Right. Well, and we have to kind of take this as a moment to say we've got to give those people some grace and say, look, we've never been through this, and neither have they, and nobody was really prepared for this to happen this year.
Well, and it's also, you have to get people on the phone. You have to get people to answer the calls. So
right.
that can be tricky these days as well.
And I'm embarrassed to tell you how many missed calls I have on my phone. So I get it. I understand. And let's also mention that the state does have this GuideSafe app that is available. And that was only initially for UAB students and faculty. It has been expanded for anybody in the state. And that app is obviously a voluntary app on your phone to get, that will essentially alert you if you have been in contact with somebody who later reported a positive COVID test. And if you were in contact with that person within a amount of 6 feet for 15 minutes. Now, we do have to say, again, that's something that that is voluntary through the state, but that's also something that a lot of people can't get, either because they don't have mobile phones or because they do not have a phone that supports that technology. I know my phone, I've got mine right here, and I've tried to download it, and my phone is not new enough to get the app. And I think that a lot of people are probably in that same situation.
Yeah. And also that app, the effectiveness, it's more effective the more people use it. And, that app probably works better in places like, university campuses or in cities where there's, a higher percentage of people who are going to be using it. Because if you're the only one with the app walking around, it's probably not going to help you all that much.
Right. Now, I want to ask you another question in a second about some differences in antigen and antibody, because I know we have some questions about that. But just looking through some of these questions really quick, Jeanette, thank you for watching, Jeanette. We appreciate you. And she asks if Dennis, you can address the costs. And I'm assuming she means the cost in rapid response versus the PCR, or just the cost of this in general.
Yeah, and that is one of the other great advantages of these antigen tests is they're relatively cheap. There are programs out where they're trying to distribute large numbers of these tests for about $5 a pop, they say. I don't know if they can quite get it that low yet, but that's kind of the goal. And part of that is because it's a more simple test. You don't need the expensive lab equipment. You don't need to have the trained laboratory technician to run the test. You can you can go into some doctors' offices have them now. Some urgent care clinics might have them. And, there's talk, I haven't seen any available yet, but there's talk that you can actually get sort of like a home test kit version of this that would work almost like a pregnancy test, where you can test yourself at home.
And that's the one JM, I think, was asking, like, can we get them now?
Yeah, I don't know that those are available yet, but I know there are a whole lot of people who would like to make that available, and they're working on it.
This is very interesting comment from Robin, who had said earlier she got a test and was not asked who she was in contact with. Robin says, I'm a teacher. I got it from an asymptomatic person. I protected my students by reporting it to my work. And this could have been a horrible issue if I had not self-reported. Robin, first of all, thank you for your work as a teacher. You are changing lives every single day, and especially right now. And also, you're so right, Robin, the fact that you got this from somebody asymptomatic, and maybe if you hadn't have reported, things could have been worse. So good on you, Robin, for reporting. We're glad you did. And, let us know how that's going for you. We hope you're doing better. Question in some of these comments, Dennis, about antibody tests. And let's just quickly address the difference, an antigen versus antibody. I know you and I, who have been in this kind of world now for so many months, even we say one sometimes and mean the other because the words are so close, but they're totally different things.
Yeah, I'll admit I've goofed on that one before, and just, my brain says one thing and my fingers type another thing. But one easy way to do this is, instead of antigen is the rapid test. So just rapid test. Antibody is a blood test. So it works completely differently from the antigen test. The rapid test is still a nasal swab. It's still, checking your mucus there in your nose to see if the virus is in there. Antibody is actually checking your blood. So, and it's looking for, instead of looking for the virus itself, it's looking for the antibodies, which are the substances that your body produces to fight the virus. And it's, it's a different thing, because, if you test positive with a rapid test with an antigen test, that means that right now in your nose you have the virus. It means probably that you're contagious and could transmit it to other people. You could have those antibodies in your blood for a long time after you've already had the virus and recovered from it, and you may not be, contagious anymore at that point. You may have, kind of gone on about your day. And so I guess one way to look at it is that the rapid tests tell you have the virus. The blood tests tell you had the virus at some point. You may still have it. You may still be contagious, but it may also have been that you had it, 3-4 weeks ago, and you're fine now.
Mm-hmm. It's that have versus had, that tense difference.
Yeah.
Just going through some of these questions again, Susie says she's still confused about the mask. So Susie will say that there is still a mask mandate in Alabama. You still got to wear your mask when you are going out in public. So I hope that quickly answers your question on that front. We had another question too about the what we were talking about earlier about the testing rates. And I know it's so confusing, so I'll say it again, and I'll let Dennis give his kind of more practical explanation. But the rapid response test, aka the antigen tests, have a high false negative rate and a low false positive rate. Dennis, can you quickly break that down again for those of us who weren't joined at the moment?
Yeah. So, and actually, it's not really a high false negative rate either. So they kind of, when the FDA, they have to approve all these tests before they go out in the marketplace. And the first ones that were approved were 97% as specific as the PCR test, the old standard test that we've been doing for March. And the other one was, I believe, 84% as effective. So it's a small percentage that we're talking about, but there is a chance with the rapid tests, because they don't send the sample off to a lab to kind of multiply the amount of virus that's there. There's a slightly higher chance that they could miss the virus. Okay, mm-hmm. that you could actually have the virus, but the test would come back negative because your count was relatively low.
And the way that I've kind of thought about that is in these rapid response tests, and this might not be the actual way of it, but it's just how my brain works, that if you are putting that Petri dish or the virus, the swab, under a microscope that has maybe 10x magnification, you might not see any virus. But if you were to go with one of those PCR tests where they can magnify it even more, you would see that there are small bits of that virus. So I hope that helps you. I think it was Melissa that asked. I hope that helps you and gives you a little bit more of a practical way to think about that, because when you say like false negative, false positive, that is very confusing, especially if you're like me. I want to quickly say, I believe it was Rebecca, works in the medical field. Thank you, Rebecca, for doing your work. We all are in a better place because of people like you. I know we have Susan, who's immunodeficient. Stay safe, Susan. And I think we're going to end here on a comment from Gail, because she says, let's agree to just pray that this virus is over soon. Everybody stay well. Gail, I think you're right. I think everybody can agree on one thing, that we are ready for COVID to be over. So thank you all so much for watching this. I hope this was helpful. If you still have questions about this, please reach out to Dennis or myself, and we will get you the answers that you are looking for. So thank you all so much for watching. Thank you, Dennis, for coming and breaking this down. And everybody, have a great Tuesday. We'll see you tomorrow.